What medical coder should know to be a great risk adjustment coder? In Module 3, we learn what does MEET stand for, and we know the two critical questions MEET answers to. What clinical or paraclinical indicators lead the healthcare provider to make the diagnosis? How does the healthcare provider manage the patient's illness or condition? The medical coders need to understand clinical scenarios in order to be able to link diagnosis to MEET. They need appropriate knowledge that allows them to identify clinical indicators in the documentation quickly. That is why risk adjustment coders require a comprehensive understanding of anatomy and pathophysiology to verify if patients present with a possible diagnosis and also if there are inconsistencies in the documentation. With this knowledge, MRA coders will know when it is appropriate to query a physician. Likewise, risk adjustment coders must have a more profound knowledge of pharmacology to be able to link diagnoses to prescription drugs when the healthcare providers do not provide that link. Besides the anatomy and pathophysiology knowledge, a good coder should also know the principal goal of risk adjustment coder, which is to make sure that the risk adjustment factor score of the medical practice improves. Know how to achieve this goal. They must ensure that all chronic diseases or conditions are documented at least once every 6 months. Make sure they have the ability to help the healthcare provider find new risk adjustment diagnoses. Make sure that the healthcare provider's documentation supports every single HCC diagnosis for validation purposes. And make sure that each date of service documentation stands by itself. Know how to help healthcare provider find new risk adjustment diagnoses, which can be done by reading before submitting claims, all parts of the notes to look for any clinical indicators that might support a new risk adjustment diagnosis. Coders will use these indicators to support their arguments for querying the healthcare provider. And by reading carefully all reports such as lab results, imaging tests, pathology report, consultation reports, and hospital discharge reports to find new HCC diagnoses. Know how to ensure the healthcare provider's documentation supports each risk adjustment diagnosis, which can be done by using the MEET strategy. Know the most common sources of new risk adjustment diagnoses, which are clinical and paraclinical. It will be easier for coders with pathophysiology knowledge to be able to exploit the clinical source. Know about documentation support and validation. A diagnosis as supported means that the healthcare provider documents clinical indicators, which may be a sign, symptom, lab result. Status of the chronic condition such as stable, improved, controlled, worsening, in remission. Management plan, which describes the strategy chosen to deal with the patient's condition or disease. It can be observation, treatment, specialist consultation, or test order. And know how to query the physician. How risk adjustment coders can query healthcare providers to improve risk adjustment factor score. All information used to abstract diagnoses from the encounter must be documented within the encounter. The physician must include all information pertinent to the encounter in the note to ensure all pertinent diagnoses can be abstracted. The coders cannot apply a clinical interpretation to information within the record. The only way they can influence the medical documentation is through physician query, which is a method of communication used by coders to request clarification from the physician about patients' diagnoses or procedures. The desired outcome from a query is an update of a health record to reflect better a physician's intent and clinical thought process documented in a manner that supports accurate code assignment. Risk adjustment coders should query the physician every time the medical record documentation is conflicting, imprecise, incomplete, illegible, ambiguous, or inconsistent, is associated with clinical indicators without a definitive relationship to an underlying diagnosis, provides a diagnosis not supported by the necessary clinical indicators in the chart. A query can be worded differently but should never be interpreted as leading the physician. A query should never be initiated without a basis of the patient's symptoms or treatment that clinically indicates a specific condition. A query can be formulated in different manners, including the following: open-ended query, multiple-choice query, yes or no query. Open-ended query. It allows the physician to clarify the documentation. Here is an example of open-ended query. A 78-year-old man with colon cancer is seen this morning for a post-hospital follow-up visit. The progress note describes the patient as underweight, with unintentional weight loss over the past 3 months. Nutritional consult notes BMI is 17.8 with muscle wasting. Recommendations include nutritional supplements and vitamins. Based on your clinical judgment, can you provide a diagnosis that represents the below-listed clinical indicators? Underweight, unintentional weight loss, muscle wasting, BMI equal to 17.8, nutritional supplement and vitamin recommendation. Multiple choice query. It is used to establish greater specificity to a diagnosis and should include options supported by the clinical indicators in the patient's chart. It should include choices such as Other, to allow the provider to add free text to indicate a diagnosis. Undetermined, to allow the provider to state that, at this time, the answer is unknown. Not clinically relevant, to allow the provider to express disagreement with the intent of the question. It is appropriate to include also new diagnosis as an option when supported by clinical indicators. Here is an example for multiple choice query. It is noted in the assessment of the progress note that the patient has chronic heart failure, and a recent echocardiogram noted under the cardiac review of systems reveals an ejection fraction of 25%. Can you further clarify your diagnosis of chronic heart failure? Chronic systolic heart failure. Chronic diastolic heart failure. Chronic systolic and diastolic heart failure. Other types of chronic heart failure. Undetermined. Yes or no query. It can be used to establish a cause and effect relationship between two diagnoses, resolve conflicting documentation, further specify a diagnosis that is already present in the chart. This type of query should never be used to verify or document a condition that is not already established in the patient's medical record. Besides yes and no, it should include other options such as undetermined, not clinically relevant, other. Here is an example of yes or no query. A 68-year-old man is seen this morning for a follow-up of hyperlipidemia diagnosed for 8 years. The patient's home medications include Lipitor, Zetia, and omega-3 fatty acid supplements. Today he keeps complaining of tingling of both lower extremities that started 3 months ago. In the assessment, the following diagnoses are documented. Peripheral neuropathy. Hyperlipidemia. Is peripheral neuropathy due to hyperlipidemia? Please document your response below. Yes. No. Other. Clinically undetermined.